It is advisable to study the appropriate essential anatomy as outlined in the Primer of Regional Anesthesia Anatomy before studying the continuous cervical paravertebral block. The cervical paravertebral block is indicated for painful conditions of the entire upper limb. It is specifically indicated for major shoulder, major elbow, and major wrist surgery, and it provides a more sensory than motor block and has a wider distribution than the interscalene block because this block is performed at the root level of the brachial plexus. It should not be done for minor surgery and relatively painless conditions. It is possible to place the cervical paravertebral block postoperatively with the loss of resistance to air technique without nerve stimulation. 20 to 40 milliliters of ropivacaine, 0.5 to 0.75%, is usually used for intraoperative analgesia, and an infusion of 0.2% at 3 to 10 milliliters per hour is used for postoperative pain management. Patient-controlled boluses of 5 to 10 milliliters with a lockout time of 30 to 60 minutes can be used if indicated. The patient is positioned in the lateral decubitus, or sitting position, for this block. A line is drawn from the dorsal spine of C6 to the suprasternal notch. Needle entry is in the apex of the V formed by the trapezius and levator scapulae muscles and on the line drawn from the C6 dorsal spine to the suprasternal notch. The dotted line is from the dorsal spine of C6 to the suprasternal notch, and the groove between the levator scapulae and trapezius muscles can be palpated. After skin preparation, the area is covered with a sterile fenestrated clear plastic drape. The fingers of the non-operative hand separate the muscles, and a 25-gauge needle is used to anesthetize the skin and subcutaneous tissue. This needle remains on the line drawn between the C6 spinous process and the suprasternal notch. The anesthetizing of the subcutaneous tissue is liberal, but only after direct subcutaneous injection. No local anesthetic agent is injected until contact with the bony pars intervertebralis articular column or short transverse process of C6 is made. Only after contact with the bone can local anesthetic agent be injected on withdrawal of the needle. This is done to prevent the theoretical possibility of intracord injection if the bony structures are missed and the needle is aimed too medially. The subcutaneous path intended for tunneling of the catheter is also adequately anesthetized. The trapezius and levator scapulae muscles are again separated with the fingers of the left hand and a 17 or 18 gauge insulated TUI needle, which is attached to a nerve stimulator set at a current output of 1 to 3 milliamps, a frequency of 2 Hz, and a pulse width of 200 to 300 microseconds, is advanced, aiming towards the suprasternal notch until contact with the bony structures is made. Notice that this needle always remains on the plane of the line drawn from the C6 dorsal spine to the suprasternal notch. After contact with the bone, the stylet of the needle is removed and a loss of resistance to air syringe is attached to the needle. The needle tip is now carefully walked off the bony structures in a lateral and slightly superior direction, remaining on the plane of the line drawn from the dorsal spine of C6 to the suprasternal notch. At this stage, the tip of the needle should be against the wall of bone formed by the pars intervertebralis or articular column or short transverse process of C6 as indicated in this illustration. After walking off these bony structures, the needle is advanced carefully in an anterior direction, remaining on the plane of the line between the dorsal spine of C6 and the suprasternal notch. Loss of resistance to air will be encountered simultaneous with a motor response. The muscles involved are usually the triceps, biceps, deltoid, or major pectoral muscles, but any muscle group of the upper limb would be acceptable for this block since the needle is now in contact with the posterior aspects of the roots of the brachial plexus. Because the posterior aspect of the roots of the brachial plexus contain mainly sensory fibers, the patient may often report a sensory pulsation just before the appearance of the motor response. This recording gives a posterior view of the loss of resistance to air and motor response appearing simultaneously. Observing the patient's mouth, it can be seen that the patient reports a sensory pulsation before the motor response appeared. This is more common in young subjects. The tip of the needle is now situated between the anterior and middle scalene muscles and is in contact with the C6 root of the brachial plexus. The nerve stimulator is now removed from the needle and attached to the proximal end of the stimulating catheter, and the tip of the catheter is inserted into the needle shaft. Notice that the proximal part of the catheter and the nerve stimulator clip can be placed in the palm of the left hand, which also holds and manipulates the needle. The right hand advances the catheter tip into the needle shaft and beyond. The nerve stimulator is usually set at a current output of 1 milliamp or at an output that is comfortable for the patient. The motor response should be unchanged, and the broad black mark on the catheter indicates that the catheter tip is situated at the tip of the needle. It is important never to manipulate the needle if the broad black mark is not completely visible. Advance the catheter beyond the needle tip. If the motor response disappears, carefully withdraw the catheter tip to inside the needle shaft. Make a small adjustment to the needle by rotating it clockwise or counterclockwise, or advancing it slightly or withdrawing it slightly. Repeat this maneuver until the muscle twitches remain unchanged during catheter advancement. This indicates that the catheter tip is now situated on the nerve root. Advance the catheter approximately 3 to 5 centimeters beyond the needle tip, but not further than 5 centimeters. Remove the needle without disturbing the catheter and remove the inner stylet of the catheter. The catheter position can now again be confirmed by attaching the nerve stimulator to the catheter. The motor response should be unchanged. The catheter will dislodge if it is not secured. The best method of securing the catheter is by subcutaneous tunneling. This is done by first placing the inner stylet of the needle subcutaneously from a point approximately 1 to 2 millimeters from the catheter exit site if a skin bridge is required to where the tunneling is anticipated. If a skin bridge is not required, the needle stylet enters through the same site as the catheter, taking care not to damage the catheter. This area has already been anesthetized. The needle is now railroaded retrogradely over the stylet, and the stylet is removed. The proximal end of the catheter is fed through the needle, and the needle is removed, leaving a loop of catheter. The silicone tubing that protected the catheter tip during packaging is handy to use to protect the skin bridge. This skin bridge makes removing of the catheter easier, but may be more prone to leaking of local anesthetic agent. Attach the snap lock to the catheter and attach the nerve stimulator to the snap lock. The motor response should still remain unchanged. Injection of local anesthetic agent or any other conductor of electricity that will decrease and disperse the current density at the catheter tip, such as saline, will cause the motor response to stop immediately. This is a positive Raj test and gives final confirmation that the block will be successful. The catheter is covered with a sterile transparent dressing and the snap lock snapped into the stat lock. Catheter removal, when the patient does not require the continuous nerve block any longer, and after full sensation has returned to the arm, is by fixating the proximal end of the catheter and then removing the distal end before removing the entire catheter.